Good afternoon. I'd like to welcome you all to the final panel of the 2023 Telehealth Summit brought to you by the California Telehealth Resource Center. Thank you for hanging in. We promise to have an exciting and interesting and fact-filled discussion this afternoon. And if you have any last questions, now is the time to ask them. We're going to be covering a broad set of issues. Today's panel is on policy and a discussion with subject matter experts that span a wide array of topics that touch on telehealth. I'm Sylvia Trujillo, the Senior Director of OCHIN, and I will be your moderator today. Today's session, as you all know, and you've heard probably undoubtedly multiple times today, is purely for informational purposes. PTRC has no relevant financial interest, arrangement, or affiliation with any organization related to commercial products or services discussed during the summit today or at this panel. Before we begin, I want to review a couple of tips that hopefully by now you guys are truly steeped in and skilled in with regard to the WHOVA event platform. First, closed captioning is enabled. If you would like to view subtitles or a running transcript in a separate window, you can access them via the live transcript icon on your Zoom control bar. Today's session is being recorded and will be posted on the CTRC YouTube channel by the end of the month. Please feel free to post your questions in the WHOVA chat or the Zoom chat windows. So for today's final presentation, we have some extraordinary talent that will be outlining broad categories of topics, starting with the federal telehealth flexibilities that have either been extended permanently, extended temporarily, or that have terminated as a result of the sunsetting of the COVID-19 public health emergency. We'll have a panelist present on this topic and the various federal flexibilities that have been impacted and their impact on telehealth. We'll have time for Q&A, and then we'll segue to another panelist presenting on the California telehealth licensure and medical practice and national trends. Obviously, with telehealth, we have a lot of providers that, while licensed in California, may be located elsewhere, and it's important to know what those trends look like. And then that will be also followed by a Q&A where we will have two subject matter experts fielding questions from you all. So start queuing up any questions you have on California regulatory practice or telehealth licensure related issues. And then finally, and certainly not least, one of the more exciting and interesting topics, and that is around online tracking technology trends and the intersection with telehealth. This has become very relevant to many people post-Dobbs. And so this is a not to be missed subsection within this panel. And we have two subject matter experts, one who will present, and then both of them will come together in order to field questions from you all and a few that I have too. So with that, I'm going to have a segue to our first mini session of today's panel. Okay, but before we do that, I want to clarify something. The terminology around telehealth, as you know, whether it's federal programs or state programs, there's no one single definition of telehealth. That is why for today's discussion, certainly with regard to this first initial panel, we will be focusing on telehealth in the context of interactive physician-clinician communication, either through interactive video, a slightly delayed store and forward, or audio only. And this is very important when you're talking about Medicare coverage, particularly what's called Part B coverage, which that's what most of us are focused on. We're not going to be talking about Medicare Advantage coverage and also DEA prescribing. However, in our second and third session, you may hear slightly different definitions to cover other virtual modalities like e-consults or remote patient monitoring, for instance, or even more innovative models and technologies that will be deployed. But we will be certain to be clear and to define what modalities we're talking about when we cover the policy issues. I also want to flag that we might be using some terms like the PFS, the Medicare Physician Fee Schedule, or the OPPS, which is the Medicare Outpatient Prospective Payment System. And last, I may inadvertently slip into acronyms. And when I say PHE, we're talking about the COVID-19 PHE, because of course there remains a public health emergency in place that's not the COVID-19 one, but the one that concerns the opioid use disorder. We are not referencing any flexibilities or issues around that, with the exception of one. So with that, I'm going to have us move to the next slide. We would like to make this a bit interactive. And so what I'm going to ask you all to do is, if you could, in your chat, answer the following. Do you offer telehealth, either interactive video or audio only? Do you offer remote patient monitoring? Do you offer e-consults? So that's the first. Answer with as many that apply. And then the last question, are you familiar with the changes in Medicare coverage for telehealth due to the termination of the COVID-19 PHE? So I'm going to be looking at that while we move to our next slide. And we are going to have Carol Yarborough do a presentation related to the post-COVID-19 public health emergency federal changes. So with that, Carol, take it away.
Thank you, and good afternoon, everyone. Thank you so much for allowing me to come and present for you. As you can see by all the acronyms after my name, I'm primarily interested in billing and reimbursement policies, but as affected by the federal policies that are either extended or waived post-PHE. So let's get into it. So there were a lot of things that changed and then were replaced post-PHE. So on May 11th, that was the end day of the public health emergency. And there were many things that were extended due to the the Consolidated Appropriations Act of 2022 and 2023. And certain things that had been excised, like virtual trainee, and then put that application, my apologies, virtual trainee supervision, as well as the allowance of HOPD providers to be able to continue to provide telehealth to patients' homes. So there were so many flexibilities associated with primarily the Medicare coverage of telehealth services, because that's what we're always worried about, is getting paid. But certainly HRSA had guidance about telehealth, and that affected where a patient could be seen, as well as what geographic location they could be seen in. OCR, certainly, their deadline's coming up in August. They allowed any platform that seemed somewhat private to be used for telehealth interactions between a patient and provider. That's going to go off into the sunset very soon. DEA prescribing is still held to what had been happening during the public health emergency. It was proposed that a definitive final rule go into policy also around May 11th. There were 38,000 comment letters submitted. And so they decided they needed probably the time to read those. And now they're anticipating coming out with a postponed final date for them to release that. And then certainly the OIG, they were allowing providers to not have to collect copays from their patients. Certainly a lot of people only saw patients in person, and to quickly ramp up and put in all the, maybe a square reader or anything like that into place at the very start of the PHE. They just said, well, don't worry about getting your copays. Medicare is still going to pay you. So the copays, there we go. The copays also apply to certain things like remote physiological monitoring. I know a lot of perhaps vendors and maybe even clinics and facilities are surprised that now they are to collect copays for those services. And certainly now that's relegated to established patients only. But there are cost waivers in effect still for certain things, but not the full gamut of everything everyone was relieved of during the public health emergency. And of course, what you got paid from Medicare was less than 20%. So it's not like you were getting payment parity if you didn't collect that copay. So it's always a good idea to collect your copays. Anyway, now you have to get to it and collect that money if you're going to continue to provide telehealth. Next slide. So I mentioned the platforms and software security. Primarily that was around, using WhatsApp or other things that perhaps had not been HIPAA compliant in the intent to provide safe and private care to your patients. So that was supposed to end on May 11th as well. OCR said, well, you know what, we are going to postpone that, give people 90 days to ramp down. Certainly when the PHE was declared back in 2020, if anyone recalls the interminable phone calls online with CMS and other entities about what was covered, what was going to happen, who could provide care, that took a long time. So certainly it's going to, well, it probably took about 120 days, but 90 days to go ahead and get your secure messaging, your secure interactive Zoom platforms or what other platform you may use that's integrated into your EMR. Now's the time to get that done and quickly, because that ends in August. So August 9th, ding, 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 get ready. Next slide. So the coverage flexibility, there are things. So I mentioned briefly at the beginning about the flexibilities that were supposed to end, which was virtual trainee supervision. There are other things that are going to end as well, but that was all extended through December 31st, 2023. There was a large hue and cry, certainly in academic medical centers, about the virtual trainee supervision going away. The direct supervision will also go away by the end of December 31st. And so direct supervision for things that are incident to, and say, a non-facility clinic or other types of healthcare where you would require a provider to be directly in the suite overseeing an ancillary or, an incident to care service taking place, an injection, things like that. And then also there are going to be some services that are going to be proposed for sunsetting in the Medicare physician fee schedule, otherwise known as the MPFS, this summer, otherwise known as Christmas in July, when the MPFS comes out in draft form, and usually early to mid-July. So I'm waiting for that. That's going to be a great day. Then there are other flexibilities probably going away as of December 31st. Geographic flexibility, we mentioned home is an eligible originating site. An originating site needs to be a facility after December 31st. So January 1st, you need to get yourself into a healthcare facility in a HRSA designated area. Audio only flexibility for anything but behavioral health will disappear as well as 99441, 42, and 43. Those are being deleted as of January 1st, 2025. FQs, rural health clinics, and we have some folks on here from these important places of service, still going to be permitted to act as distant sites permanently, I think. Okay, we'll get back to that. We got another year to figure out the nuts and bolts on that. OTs, PTs, speech language pathologists, audiologists were provided the ability to see their patients in their homes through a hospital without walls initiative during the public health emergency. Again, because of the hue and cry about stopping someone's care, perhaps mid-treatment during, between May 11th and May 12th, that has been extended through the end of 2024. Now, the ability of a hospital outpatient department to do so may end the end of this year, but there's legislation pending, there's policy analysis pending. So all of this, as of now, is what's happening. But, as with anything with the government, it can change on a dime. Surprisingly, change on a dime. I've never seen things change so fast. Other than with regard to telehealth. Waiver at least one in-person requirement for telemental health. So that will end, and that is also under consideration as well. Many behavioral health providers are stating that, okay, so there's no requirement that a patient establish care during the PHE. We've met with no difficulties or rampant fraud during this time period. So why do we have to get rid of it now? Just because this is talk therapy. It's not like anyone's body in my office is going to make a difference. So that's what you have to look forward to, perhaps advocating on behalf of your providers. So the prescribing of controlled substances was primarily the impetus for having patients come into an office due to the Ryan-Height Act that had been implemented. The PHE allowed controlled substances to be prescribed and obtained by, right, Beju. She is looking forward to advocating. That's awesome. To be prescribed during the PHE, and certainly been very life-saving for many people to obtain this type of care. Whether economically they can't make it into a clinic or a substance use disorder clinic, or even to get your ADD meds because, there's fraud surrounding that type of thing. Or probably diversion is probably the most feared of result of allowing this to take place online. Well, this isn't online shopping. This is not drugs by Amazon. This is meeting your provider, having them see you, and then getting your meds renewed via behavioral health interaction online. As you can see, there are different schedules for types of drugs. And so primarily this is surrounding 2 through 5. So stay tuned on that. They are pending release of a formal policy. We have heard that the special registration that we'd anticipated to be announced during that rule release, I think it was April or May, probably April, but the DEA says it's too burdensome to implement the special registry. So it'd be nice to know what's hard about it. And I would be happy to offer my typing skills for that if it's needed. For pay, of course. Okay, next slide. All right, so I can't claim this beautiful slide, but Sylvia did put this together, and it is a gorgeous slide. It puts everything out on a timeline that's easily understood. So May 11th, that was the end of the public health emergency. As we know, it's not the end of COVID. 185 people still continue to perish from COVID daily, even though numbers have gone way, way down. But the waivers that have been put in place to allow for online care, that probably was the main impetus to end the PHE, certainly in terms of mandates around vaccines and what businesses could and couldn't do. So there was a lot of pressure on the White House. So as mentioned, OCR, you have to get compliant with your telehealth platform. FaceTime is encrypted. but it's not exactly compliant. So August 9th, November 11th, that's going to be our DEA deadline. December 31st, direct supervision, virtual trainee supervision, payment parity, that is going to go away as of this year. November 11th, 2024, any kind of flexibility at all. So this is for when drugs had been established during the PHE, when you had established a prescription with a patient during the PHE, which extended over into the following year, that is going to go away. So that's when you know when you need to have audio only appointments not qualify someone to receive medication and treatment of their opioid use disorder. They do have to go in for one visit, and then, you know, everything can follow after that. And then the flexibilities that we discussed earlier are going away December 31st. But, you know, fingers crossed, advocate with your Congress people. I had the opportunity to go to the Hill last week and, you know, kind of put our points across in terms of California, what California would like, and what certainly what UCSF can advocate on behalf of, since we are a government entity ourselves. But I encourage everyone to just dig into the MPFS this year, read the portions that ascribe to you, and write your comment letters, because they do and they will read every single letter that's sent in.
Great. So we're going to go back one slide to just sit at the timeline so folks have an opportunity to soak that in. We do have time for questions. So if you have a question for Carol, please go ahead and post that in the chat. What I'd like to do now is to pivot back, Carol, to a couple of the flexibilities that you outlined. So we can do a little bit of a deep dive. You covered a tremendous amount of ground really eloquently and clearly, which is challenging in the limited time allotment and the issues that you had to cover. So the first one has to do with HRSA. Can you expand a little bit on the flexibility that HRSA has provided around telemedicine?
HRSA itself, well, that would be the geographic and originating site waivers. So that is extended through December 31st, 2024 as well. The Congressional Budget Office wants to collect data to see if telemedicine or telehealth services will keep the Medicare program budget neutral. So the more data they can collect, now that it's been finally established, prior to the PHE, it was very hard for them to get data to try to see if telehealth was an additive component to healthcare or whether or not it was substitutive. So with this extra data, the CBO, I think within 6 months is supposed to create a report, or somebody within the organization, perhaps HRSA, I can't recall exactly who, provide a report on whether or not the Medicare fund, the endowment, remains budget neutral due to these extra or perhaps substitutive care. Certainly having people obtain care via this modality can keep them out of hospitals. And I really do hope longitudinally they're going to be looking at Part A perhaps going down if people get Part B. So, you know, it's all a big environment of payment for the government. So hopefully they'll look into that as well.
Yeah, so really fascinating tie between our plenary session this morning, where the AMA presenter, Chris Corey, outlined that there was a study that demonstrated that the outcomes for patients who had had a combination of telehealth and in-person versus those who didn't have any, just in-person and no telehealth, actually had better outcomes. And I think that's a really interesting study design to augment the methodology that the Congressional Budget Office is using. And then I also want to expand on for our FQHCs who may be listening in and participating, that in addition to the flexibilities that have been provided under the Medicare program, HRSA has extended those flexibilities for providing telehealth services outside of your service area. It needs to not be sort of the core of your service delivery, but that's an important flexibility so that those patients who are the most underserved can continue to receive their services, even if they happen to be outside the service area of their primary care provider, either because of where they work or they live, or they just happen to be traveling, that they can continue to receive those services. So Carol,
Correct me, Sylvia, I want to ask you really quick too, is so the behavioral health component that they can continue to provide as behavioral health providers, that's not going to be included in the AIR, the acronym AIR. What is it? Something.
it's part of their PPS. It's like the
Yes.
equivalent of a prospective payment system. So
Yeah.
as opposed to like fee for service model. And
Right. So they're going to be able to do behavioral health outside of that and become distant site providers for behavioral health outside of that daily all-inclusive amount. And I think that was implemented that way so they could provide behavioral health and not get the full, I don't know, what is it, $200 per day when a patient shows up for all the services they got. They can continue to do behavioral health, but get the MPFS rate for that. Is that?
we'd actually want to verify that. I don't know the answer to that
I'm
question, but I
pretty
think it's a
sure.
really good one.
Yeah.
And that's something in the slides that we'll have available. We can follow up. But the thing that we know unequivocally is that they've extended, HRSA has extended for a time that they actually can continue to go outside their service area, which is really an important flexibility for FQHCs. And I think the other thing, Carol, maybe I think we do have a little bit of time to touch on this, is we've been talking about Medicare, and of course there's Medi-Cal coverage, and that's different. The coverage issues there have been dealt with earlier by the California legislature with regard to either permanent extensions or modifications of Medi-Cal coverage for telehealth. Is there very high level? Are there any sort of general observations you'd want to offer with regard to coverage and the Medi-Cal program in the context of telehealth?
Someone might get into this later, but I did get to participate in providing CPT definitions to DHCS so that the continuous glucose monitoring is now a covered service for pediatric patients as well as adults. So that was effective as of May 1st. So all you pediatricians out there with kids with diabetes type 1, you can now bill for CGM 95251, 95222, something. So that's a really great outcome of differentiating between what is actually considered virtual care versus virtual monitoring, because CGM is actually remote care because it's reporting on data accumulated over a period of time, whereas RPM has different kind of payment requirements. So it doesn't quite fit into that, what you would consider to be an accumulation of data for somebody's glucose, as opposed to making sure that they've done it, or maybe they're doing finger sticks and reporting that through RPM. So that's a nice differentiation that Medi-Cal did come to understand. And that's a win for our pediatric patients. So I'm super happy about that.
Right.
There was a really great work done by advocates in California for that.
So we probably will come back to this. So Carol, I just want to thank you for your continued both subject matter expertise and your educational outreach to support the adoption of evidence-based approaches integrated into a whole sort of care team of delivery, and also your advocacy on behalf of patients and providers. So with that, I'm going to segue to our next slide and to our questions for the audience. And this is where we're going to tee up a sort of looking at broad national trends and what that means in the context of California. And Caitlin is going to be presenting, and then followed by a Q&A by both Caitlin and Jade. But before we get to Caitlin and her introduction of herself, I'm going to have the audience give us some feedback about what kind of telehealth services, and not so much services you offer, but who is paying for the telehealth services for your patients? Is it Medi-Cal? Is it Medicare? Is it commercial plans? Is it self-pay? And I'm assuming it's probably a combination of all the above. So if you could say the primary, payer mix that you're looking at, that'll be really helpful for some follow-up questions we're going to have. So go ahead and pop that in the chat. And I'd like to thank Caitlin. If we could move to the next slide. And I'm going to hand it off to you to give us a broad overview of these really important trends in telehealth.
Thank you so much, Sylvia, and great job, Carol. It was always great to hear from you. So for those who I haven't met yet, my name is Caitlin Otis. I am an associate at Foley and Lardner. I am a member of our digital health industry team. My practice primarily focuses on advising emerging telehealth companies on multi-state practice standards and licensure requirements, as well as various corporate practice of medicine issues. I work closely with my colleague, Jade Beverly, who you'll hear from shortly. We're here today to talk primarily about licensure and practice standards, primarily in California, but also discuss slightly emerging trends that we're seeing all over the nation and on a national platform. So before we can get into a discussion of general telehealth practice standards or licensure requirements, I think it's important to set the stage of what exactly we're talking about when we say telemedicine. So if you look at 50 different states, you're going to see 50 different definitions of telemedicine or telehealth. For purpose of our discussion today, as Sylvia pointed out earlier, we're going to follow the Medicare definitions when we talk about telehealth. So that primarily will include real-time audio-video communications. So when we say that, you're thinking of exactly what we're doing right now. We're talking about a Zoom call, a FaceTime call, something where you're both face-to-face, interacting, able to communicate with each other in this type of level. We also, when we talk about telehealth, include just an interactive phone call. So what that means is just pick up an audio only phone call, whether that's through Zoom or through just your doctor calling your personal cell phone. We've recognized that now as an acceptable method of care. So that's how Medicare typically defines telehealth, and that's in recognition of multiple state trends that we've seen over the years. Previously, you saw it limited primarily to real-time audio video, which required both parties, like I said, to get on a video call and talk through, face-to-face. But outside of just the Medicare context, there's other definitions of telehealth. There's other modalities that could be referenced when somebody says telehealth. So if you look at, for example, Medi-Cal, when they say telehealth, they additionally include asynchronous store and forward. So when you think of asynchronous store and forward, I think it's best illustrated through an example. Asynchronous store and forward is, think of a teledermatology appointment. If you have, let's say, a mole on my wrist, I would send a photo of my wrist to my dermatologist. We wouldn't communicate face-to-face. We wouldn't be on a phone call, but they would receive my image. They would look at the image, diagnose it with whatever tools they need, with whatever information I've provided in my medical background, and then they would render a diagnosis and push that information down to me. Depending on the state, that could include a prescription, follow-up care, instructions, anything of that sort, and that's considered a valid modality. You also can have what's known as an interactive store and forward. That might include a phone call plus what we just talked about for pushing an image while you're on the phone with your doctor. So various states define telehealth differently, and it's important to know exactly what a state permits when you're looking at what modality you would like to use as a provider. Before you provide care to a patient in a state, you need to be properly licensed in that state. So typically, a physician offering care via telemedicine is subject to the licensure requirements of both the state in which the patient is physically located at the time of the consultation, as well as the state where the physician is located and or licensed. So how is that possible? Why is that the case? You're going to be subject to the laws of the state in which the patient is physically located, because that is the jurisdiction over the patient. That's the medical board rules, the laws that are in place, and those are going to govern exactly what you need to meet in order to provide care to that patient. You'll additionally be subject to the licensure requirements where the physician is physically located. That's because that medical board can take action against your license if something goes wrong in the state in which the patient's located. Anything that comes about either on a disciplinary scale, a legal scale, action can be still taken against your license, even if you're not rendering care to a patient located in that state. So when we're talking about licensure or just general practice standards, the generally accepted rule is that the law that governs the consultation is the state where the patient is located at the time of the consultation. That's what's known as the locus of care. California specifically follows this rule. So to provide care to a patient in California, a physician needs to be licensed in California or meeting an applicable practice, applicable licensure exception. Skip slide. So there's several licensure exceptions that a physician could meet. So if you're located elsewhere, you're not licensed in California, you can meet a licensure exception. These are important because they do offer a way to provide care to patients when you're not physically located in the state or aren't able to get licensed in the several states, but you're building out a multi-state practice. However, they're difficult to meet. In order to rely on a licensure exception, you need to make sure that you're following square on all fours of the licensure exception. So common exceptions that we see across the states include a peer-to-peer consultation exception. This exception allows an unlicensed physician to practice medicine in a peer-to-peer consultation with the physician licensed in the state. These also, you could hear the term e-consults. That's where two physicians are located in different states typically, and they consult with each other either over Zoom, via a phone call, or even just over email. There's a bordering state exception. This would allow a physician or other practitioner to practice medicine while in a bordering state. So if you're in California, if California recognized it, you would be able to practice in California if you were a physician from Nevada. Some states also permit special licenses or registration. These are abbreviated licensure pathways where typically a provider will not have to go through the full licensure process, but they can register with the state and they could provide services on a limited telehealth basis so long as their registration is active. Hawaii's bordering state, that's a great question. They probably don't have one. So another common exception that we see is follow-up care. This allows a physician to provide follow-up care to his or her patient. This is especially important when you have a patient that's traveling or a patient that works remotely, as a lot of us do nowadays. So as your patient travels, you would be able to continue prescribing to them, continue meeting with them over Zoom, over audio-only phone call, just being able to continue that care until they're back in your state. Sometimes you'll see time limitations on this. It can only be for a period of 12 months, or you must see that patient in person at least once every 6 months, but it varies by the states. And then you also have these interstate licensure compacts. For example, the FSMV compact, that's where a group of states can adopt legislation where they acknowledge that they will provide reciprocity for physicians who are licensed in other states who are members of the compact. I believe right now, Jade can correct me if I'm misspeaking, but I believe around 30 states participate in this licensure compact for physicians. And so there's a common misconception around what a licensure compact means. So a lot of people think of it that if I'm licensed in Florida and I'm in a compact state, I can just fly to California and start rendering services. That's not true. What it really means is that it offers an expedited pathway to licensure. So while typically it could take anywhere from 3 weeks to 6 months to gain licensure in a state. If they're a member of a compact state, if the state is a member of the compact, then it could take anywhere from 2 days to 3 weeks. It's an extremely shortened timeline. For purposes of this presentation, I want to highlight what licensure exceptions are available for practitioners in California. So California does not have a bordering state exception. They do not have a special licensure, registration, or follow-up care exceptions, but they do have consultation exceptions. So a peer-to-peer consultation exception in California requires that the physician be in actual consultation with a provider located in the state. It also restricts the out-of-state provider's ability to open an office. They can't appoint a place to meet patients. They can't receive calls from a patient while they're within the bounds of the state. And they cannot exercise ultimate authority and care over the diagnosis of the patient. But under California law, you can provide services to another provider in the state if you're falling within that exception. Other common exceptions that you see in California include a sports team exception, an Olympic trials exception. So if you're looking to provide services in the state and you're not able to obtain full licensure, it is worth looking to see if you can fall within an exception if it is a short-term, one-off type of care that you're trying to render. So general health telehealth practice standards, these vary widely across the state. As I previously discussed, you're going to be wanting to look at the practice standards where the patient is located. That will dictate the level of care that's required to be rendered. It'll dictate how your process looks, what modalities of care you can even use. So to just run through some of the typical practice standards that we see across the states, a lot of times you'll see different requirements for a new patient versus an established patient. So what that means is if I'm a first-time patient and I'm trying to establish a physician-patient relationship via telemedicine, in certain states that will require me to either be in person for my first visit, or it could require me to be on an audio-video synchronous communication like a Zoom. That is the gold standard when we're advising clients, but some states also will permit you to establish that physician-patient relationship in that first visit through just an audio-only phone call. Typically what we see across all states is that for established patients, that level required on the first visit is typically more lax. So if a state will require you to have an audio video synchronous visit on your first visit with a patient, once they're an established patient, you can use other modalities such as asynchronous store and forward or audio only. So that's a trend that we see typically across the states. You will also see requirements to verify a patient's identity. Some states require this in a specific manner, such as seeing the patient's license, confirming their social security number, or some other personal identifier. But some states just say you have to, in some manner, verify that patient's identity. You also will see originating site restrictions, meaning there's restrictions on where the patient can be located at the time of the consultation. Patient telehealth site presenter, these are typically involves another healthcare provider that has to be with the patient at the time of the service. We've seen a severe decrease in states that require that as telehealth has expanded and become more consumer friendly. There's also specific restrictions on remote prescribing requirements, record keeping and record sharing requirements, informed consent, patient's provider of choice, and disclosure requirements. So to highlight the broad level things that any provider who's practicing in California should be aware of, California does not differentiate between a new patient and an established patient when you're talking about the modality required when you're providing services through telehealth. California is also extremely liberal in their definition of telehealth and how you can establish that physician-patient relationship. So under California law, you can establish a patient relationship either through an audio-video visit or even through just an online questionnaire. That's a recent change as of 2019, and it makes it extremely easy for patients to get the care that they need and for providers to render those services through telemedicine. In California, you are also required to verify the patient's identity. California does not dictate what manner you must do so in, but they have noted in disciplinary actions that to not verify a patient's identity, to take no steps to verify a patient's identity, is an extreme departure for the standard of care. So when you're rendering services, just taking some approach to ensure that the patient that you're communicating with is the patient that is whose medical record you're looking at. California also permits remote prescribing via telemedicine. They permit prescribing of controlled substances, obviously subject to federal requirements and other state level requirements. But you can provide non-controlled substances as well as controlled substances. There are also informed consent requirements. In some states, this will require telling a patient exactly the risks and benefits that may be associated with telehealth, telling them where they could receive follow-up care in the event of emergency, in the event of a failure of the technology, exactly what the risks are. California keeps it fairly broad. In California, you are required to inform the patient of the risks of using telehealth, defined very broadly. However, the provider will define those risks, and the patient must consent either verbally or in writing to assume those risks of providing services through telehealth. That's all I have on this slide, but I know we have some follow-up questions, which we are excited to get into.
Yes, so before we do that, I'd like to have Jade introduce herself and a little bit about her background before we jump into the question.
Hey everyone, my name is Jade Beverly, and I am the healthcare attorney and member of Foley and Lardner's healthcare practice group and our national telemedicine and digital health industry team. I focus my practice on regulatory and compliance issues in the healthcare industry with an emphasis on telemedicine and telehealth, advising on multi-state practice standards and related issues. So I'm really excited to be here today. Thanks for having me.
So I have a little bit of a curveball in both. I'm going to start with Jade, since Caitlin did the presentation around what providers in California can expect. And we've had a lot of discussion during the California legislative process. And Carol, why don't you come on just in case you have some insights about this as well. That essentially they, particularly in the Medi-Cal program, beyond the regulatory requirements that you just laid out, payers can also impose requirements that are not considered regulatory, because what they're simply saying is, yes, the laws may say you can do X, Y, and Z in terms of practicing medicine if you have licensure or you have some applicable exception. But then a payer like Medi-Cal can come in and say that, yes, that might be the case, but we want to make sure that our patients that are receiving services as beneficiaries under the Medi-Cal benefit have the option of an in-person provider. And have you seen or have familiarity with this trend where increasingly providers, or not providers, insurers may be saying, yes, it's permitted for a telehealth provider located outside of California, but not in close geographic proximity to a patient, for them to deliver care. But increasingly, they're looking at whether or not there's some relationship that that virtual provider has with an in-person provider that the patient can access, or alternatively, that a patient have the option of receiving their care either virtually or in person. So Jade or Caitlin, are you seeing anything like that around the country? Is that something that normally you all would track? Your thoughts on that would be welcome. And then I can segue over to Carol to see what she's been to.
So I'm happy to start with that. So yes, we have seen that requirement come up. I think primarily in the payer world, particularly I think Texas is one state that has this requirement, and Medi-Cal is another state that has it. But essentially, in January of 2023, this year, there was a new Medicaid manual implemented, and that was from the California Department of Healthcare Services, and there was an updated Medicare provider manual for telehealth. This update incorporated some of those legislative changes that you were discussing that were from the 2022 session. And one of the things that's now new and that providers are going to be required to do is that with regard to, there's a couple of aspects of this. So when you have providers who are offering healthcare services via an audio only modality, there's a requirement that they'll have to phase in a approach that provides patients with the choice of also having an interactive modality to preserve that patient choice. This is going to be by a date set by the department that's expected not to be sooner than January 1st of 2024. But then in addition, the department is supposed to issue guidance on this requirement during this year. Now, effective on that date that's set by the department, the providers that are offering, interactive video, audio only synchronous interaction, Medi-Cal is now imposing this requirement that the providers also have to offer those same services through in-person visits. And interestingly, and this is likely going to be in many cases, the providers, they're not going to, if you're a telehealth only provider, that's probably not going to be possible. So the providers must then arrange for a referral to and a facilitation of in-person care that does not require the patient to independently contact a different provider to arrange for that care. So I think that's, a trend that's likely in place to preserve, the patient's right to accept telehealth. And just as Caitlin mentioned, with regard to professional practice standards and requiring, the patient to consent to telehealth, this is, something else that, we're seeing. And just another thing to add on that point too, there is a pending bill that would, hopefully loosen the requirements with regard to referral facilitation to in-person providers. But, it's not yet passed, but there's it's an assembly bill, and that bill would just lighten up some of those requirements.
You nailed it. You got it exactly right, Jade. I think for everyone listening here today, it's helpful to understand that in addition to tracking what's happening in the regulatory space, just because the regulators or the medical board says you can do X, Y, and Z, we're increasingly starting to see in this state some California, once again, being a pace setter, is really creating some parameters around, through the Medi-Cal program, around what kind of arrangements are going to be acceptable, and really driving towards standards of practice. Caitlin, it looked like you were about to come off mute and say something, or was I just anticipating that?
Oh, just jumping in, you asked if we've seen this trend across the country. We've not seen it exactly the same, because obviously, as you said, California does kind of set the pace on these types of things, but we have seen an increase in a number of states that do require, as a telehealth provider, to be able to identify and disclose to a patient where they can receive follow-up care in their actual location. So even if a provider is located out of state and able to practice, they need to be able to identify to that patient if they're trying to receive follow-up care somewhere in their local community that they can go to receive that care. So I think it is a national recognition of the importance for patient care in their own community.
Yeah. So both Carol and I have been sort of involved in the legislative process as it's unfolded, and we can attest to, I think, Jade, the conversations that have been going on, including the bill that it's making its way through the legislature now, which, I think there's a 50-50 chance of passing, so it's not certain, where essentially sort of the implementation date and some of the requirements around how you do that referral as opposed to like a facilitation. One is much more required to be much more active, which is what the current requirement will be going into effect. So with that, I'd like to segue into questions around what you're seeing around in-person. That again, the regulatory requirements for in-person are pretty well established, but are you seeing policies on potentially the payer sides that basically act as a backstop against what's being allowed on the regulatory front as the state as a regulator versus the state as a payer? And commercial payers too. Are you starting to see some changes around audio only in particular? During the PHE, there was lots of flexibilities across the state, from commercial payers to the Medi-Cal program. and certainly at the federal level with regard to Medicare, but now we're starting to see a little bit of a retraction around that. Any insights, Jade, you'd like to share about what we're seeing in terms of trends around audio only?
Yeah, so I think it's twofold from the professional standpoint. A lot of the professional regulations and standards, they seem to be more lax in that they're not defining modality and mostly leaving it to the professional judgment of the provider that's providing the healthcare services. But on the other side, on the payer side, and specifically with respect to Medi-Cal, there are some scaled back and some new requirements. I think for Medi-Cal, so while they don't require, like in the new requirements that took effect in January, not requiring face-to-face interactions between a patient when the providers providing the healthcare services by interactive video, audio only, remote patient monitoring, or the other permissible virtual communication modalities. When the provider is establishing a relationship through an interactive video, there's some requirements like they can do that, but then they can't do any other modalities unless they're falling under a certain exception. So specifically with regard to the audio only modality, there's like a couple situations where the providers are able to establish that new patient relationship, and that's when the patient requests to use audio only modality, or the patient attests that they don't have access to a live video, and so they have to use the audio only. And then also if the visit's related to what's defined in it's the Medicare manual, but as a sensitive service, and there's some specifics in the manual as to what that is, but generally it's healthcare services that are related to mental or behavioral health, sexual and reproductive health, and things of that nature.
So I want to thank both of you and Carol for being ready to be on call. This is a powerhouse of knowledge in terms of the regulatory and practice of medicine and clinical practice in the state of California. And I want to thank both of you, in addition to our good friend Carol, and our expert who's always ready and very steeped in these issues. If you all could stay online, we may have a rapid fire set of questions, but if we could move to the next set of questions for our audience. And this is really an exciting area. Not that the rest of it wasn't exciting. I think telehealth is always innovating and breaking new ground, but certainly our next presenter and our next SMEs during our Q&A are really breaking the next frontier of issues. That as you're doing telehealth and you're using virtual platforms, you need to be thinking about some of the new regulatory environment that's out there. And the implications for privacy, and really as a nation, we're having another reset on the discussion around patient privacy and information sharing and information tracking. So the question I'd like for audience to go ahead and drop into the Q&A, if you could respond to the questions of, do you use certified health IT to conduct your virtual care or to bring in patients to your virtual care, and are you using a HIPAA compliant platform? So with that, I'd like to turn it over to Jennifer for her introduction. If you can move to the next slide and take it away, Jennifer.
Great, thanks so much, Sylvia. I'm glad you find data privacy and the tracking technologies to be as exciting as Erin and I do. That's good to hear. I'm Jennifer Hennessy. I'm a partner in Foley & Lardner's Madison, Wisconsin office, and I spend all my time advising on data privacy and cybersecurity related issues, largely in the healthcare space. And so I have spent a lot of my time the past couple of years talking to healthcare organizations about their use of tracking technologies long before we actually had guidance from HHS on that topic. So really thrilled to be here talking to you about it today. If we could flip over to the next slide. So this portion of the panel is going to focus on the Department of Health and Human Services regulation of tracking technologies mostly. And for those of you that might not be familiar with what we're talking about when we use the phrase tracking technologies, the term is really referring to scripts or codes that run on a website or a mobile application. And they gather information about the users of that website or mobile app as they're interacting with the website or the app. And then the information that's collected is then used to gather insights about the user's online activities. And so essentially we're talking about things like cookies, web beacons, and tracking pixels, just to name a few of these tracking technologies that we're talking about here. And before we talk about the specific HHS guidance that came out this past December, really pretty recently, 6-7 months ago, I want to talk a little bit about how we got where we are. So in January of 2021, the FTC took enforcement action against the developer of a fertility tracking application that was largely used by about 100 million consumers. And the enforcement action was based on the application sharing of health information with third-party vendors that provide marketing and analytic services, so essentially tracking technologies, with the key being that the application provider had promised these users that it was keeping their information private in a way that turned out to not really be accurate. So fast forward about 18 months to the summer of 2022, there was an article written that got a lot of traction that was analyzing hospitals and healthcare systems' use of tracking technologies on calendaring applications. And essentially the reporters went through these websites of a lot of hospitals and health systems and found that there was tracking technologies on the website that was sending data to third parties when a person was clicking a button to schedule a doctor's appointment. So again, starting to see more interest and attention to this issue. June 24th, Roe versus Wade was overturned, and there's additional concern about tracking technologies, location tracking, all of that. And then in August 2022, we start to actually see hospitals, health systems reporting data breaches related to this activity. So then that leads us to the main event that we're talking about, December of 2022. We actually have the bulletin from the OCR, the Department of Health and Human Services, that specifically addresses the use of these tracking technologies on protected health information, which is the type of information that's regulated by HIPAA. And there's a lot to unpack in that bulletin, and we're going to do our best today to walk through it in a way that's understandable. And it looks like we're already on the, we want to go back one slide, actually, the one entitled Protected Health Information. The main takeaway from the bulletin is that HHS expressly states that HIPAA-regulated entities are not permitted to use tracking technologies in a manner that results in an impermissible disclosure of protected health information, or PHI, to the tracking technology vendors. And perhaps that seems like common sense, but before that bulletin came out, we actually did not have that guidance from HHS. So we had a lot of healthcare organizations, digital health companies, health systems using these tracking technologies. They were largely used. And we heard a lot of organizations saying things like, well, if it's not permitted to use these, why wouldn't the government say something? Surely they know that these are largely used in this space and have been for years. Well, in December 2022, we got that. We got the wish that some people had been asking for. We got the guidance, and they very clearly state that use of tracking technologies on PHI has to comply with HIPAA. And for those of you that might not, live and breathe HIPAA like Erin and I do, HIPAA applies to protected health information or individually identifiable health information on a HIPAA-regulated entity's website or mobile app. If it's collected through the use of tracking technologies, disclosed to tracking technology vendors, or created, received, maintained, or transmitted for or on behalf of that HIPAA-regulated entity. So the way that data used or disclosed by tracking technologies can be regulated by HIPAA is really pretty broad. And the definition of PHI under HIPAA is also very broad. As a lot of you probably know, it includes demographic information and other information related to the health, physical or mental health, and payment for that healthcare collected by the covered entity or business associate. And so we knew the definition of PHI under HIPAA itself was very broad, but in the bulletin, HHS even takes a broader view of what is considered PHI than I think a lot of us in the industry thought that they would do. So HHS actually states that individually identifiable health information includes medical record numbers, addresses, dates of appointments, IP addresses, geographic location, medical device IDs, and other unique identifiers that might be collected. And in addition, they expressly state in this guidance that all of this information collected on a regulated entity's website or mobile app generally is going to be considered PHI, even if the individual doesn't have an existing relationship with that regulated entity, and even if the information does not include specific treatment or billing information. And that statement in the guidance was really far-reaching, and I think not expected by a lot of people. So if you think through the implications of that, which we'll dive into a little bit, they're essentially saying that collecting IP address on on certain websites and on mobile applications, even if I'm not a patient yet of that healthcare organization, that IP address alone could be regulated by HIPAA as PHI. And so that has very broad implications of the type of data that can be collected by tracking technologies and still be in compliance with HIPAA. And the rationale for this is HHS states that when a regulated entity is collecting the information on their website or app, it's indicative that the individual has received or is interested in receiving healthcare services or benefits from that covered entity, and therefore is related to the past, present, or future health of that individual, and therefore falls into the definition of PHI. So again, very, very broad. Next slide, please. What the guidance does is it breaks down the use of tracking technologies into 3 separate categories. So they address mobile applications, user authenticated web pages, and then unauthenticated web pages, all separately and very specifically. So with mobile applications, HHS really shuts down the use of tracking technologies on mobile apps that are offered by HIPAA covered entities or their business associates, essentially. Because of the way that how a mobile app functions, it says that the data collected by tracking technologies through the mobile app is essentially going to be PHI, and it's going to have to be collected in accordance with HIPAA. Similarly, with user authenticated web pages, which are web pages where the user needs to log in essentially before they're able to access the web page, such as like a secure patient portal is a common example in the healthcare space. Data collected through the user authenticated web page is generally going to be PHI, and any tracking technologies used on an authenticated web page is going to need to be done in accordance with HIPAA as well. So mobile apps and user authenticated web pages, pretty restricted on how you're going to be able to use tracking technologies. Where there's a little bit more wiggle room or gray area is on unauthenticated web pages. So if you think of a general landing page of a healthcare organization's website, for example, anyone can go there, you don't need to log in. HHS leaves open the possibility that the information collected on that type of web page may not be regulated by PHI in some instances. So for example, if someone goes to a web page just to browse like general services available on a health system's website, there's lots of services. They may or may not be a patient, they might be a visitor, they might be a vendor, lots of reasons you could be on that web page looking at general information. However, HHS of course has to make it complicated, they can't leave it there. They say that if the web page has information on specific symptoms, and they give the examples of pregnancy or miscarriage, for example, then that information collected on those types of web pages could be PHI in that instance. They also give an example if a web page allows you to go look at specific doctors to schedule an appointment with them. That could be considered PHI at that point. So they of course don't provide a clear line at when an unauthenticated web page crosses over where the information would be regulated as PHI. But at some point on those unauthenticated web pages, the information can become PHI. So even on unauthenticated web pages, HIPAA regulated entities need to be really careful about how they're rolling out these tracking technologies and being really mindful about the type of data that can be collected by these organizations. And of importance of, we're focusing a lot on the HHS guidance here because it's specific and the telehealth conference with healthcare organizations. But even if you're able to conclude that the information is not HIPAA protected health information, that is by no means the end of the story. That is just one law and one regulatory agency. But then you have to look at other laws. For example, since we're in California here, your favorite California law, the California CCPA, that of course regulates the selling and sharing of personal information with third parties. And we know that the use of tracking technologies and cookies is considered selling under California CCPA. So CCPA exempts out HIPAA PHI from its regulation. But if you are saying it's not PHI, you need to look at whether it's personal information regulated by California CCPA in that instance. The Federal Trade Commission also, we could do a 2-hour-long presentation just on the FTC enforcement actions in these areas. They, in the past year, have been looking at this issue very carefully as well. There have been some enforcement actions. Certainly HHS and HIPAA are not the only things to be concerned about in this space. Next slide, please. That leads us to what is a HIPAA regulated organization to do now in this space? Well, the first thing is figure out if you've been using tracking technologies or are still using tracking technologies. And if you are, what type of data is being shared with the third parties and what laws is it regulated by? So are you sharing data that's HIPAA PHI? If not, what is it regulated by? What are the parameters that you need to follow to share that data with third parties performing these services on your behalf? If the data is PHI, most likely you need to cease the use of the tracking technologies unless the vendor will sign a HIPAA business associate agreement with you, or you can get authorizations from the patients to share that data. In those two instances, sometimes you may be able to do it under HIPAA. The difficulty is a lot of the big players in this space don't sign HIPAA business associate agreements, so it's not as easy as it seems with getting a BAA in place. As you're doing this investigation, document it carefully so you can assess whether you have any reporting obligations, whether it's under HIPAA or other laws. So if there was a use or disclosure of PHI in violation of HIPAA, you of course need to assess whether you have a reportable HIPAA breach. You want to have thorough documentation either way you come out on that determination so that you have that if questions are ever asked in your files. And as I mentioned, going back even to August 2022, organizations have been reporting HIPAA breaches for improper use of these types of technologies in a way that they believe violates HIPAA. And then outside of HIPAA, review your privacy policy. So it's very important under FTC in particular that there is a public-facing privacy policy that accurately reflects the personal information that's being collected and how it's being used and disclosed. And that includes disclosures for advertising and marketing purposes to third-party tracking technology companies. So if you're using those types of third-party services, you don't want to be making assurances to consumers, whether it's in your privacy policy or on your website or otherwise making public statements that information is kept private at all times and it's never sold. And those types of statements are the ones where we've seen people get in trouble with regulatory agencies and in particular with the FTC in the past year. I will end there because I'm right about at time and I want to make sure we have time for questions. And thanks so much for having us here to talk about this topic.
Thank you, Jennifer. And now I'm gonna, before we start and dive into our questions, have Aaron introduce himself, and then we'll pivot and start questions with Aaron, and then open it up. So Aaron?
Yeah, so really nice to meet everyone. Aaron Margareggi. I am a senior counsel in Foley's Tampa, Florida office. I'm a healthcare lawyer by trade. I focus primarily in the privacy, e-commerce, security, and healthcare advertising space. What I like to tell people is if it involves data, either Jennifer or I are usually involved, and that can be moving it, using it, begging forgiveness, depending on how you use it. And so anything data related is sort of my wheelhouse in the healthcare space. Really excited to be here and looking forward to the questions.
Great. So, Aaron, I'm going to start with you, and I'm a hypothetical healthcare provider, and I have a website, and I have patients who are coming from out of California, and I'm providing care to them. I'm because they're coming from outside of California to receive my care. They also may be moving around the state, so I may be providing telehealth services to them as they move around the state. What kind of considerations should I be thinking about? I may or may not consider their interactions with my website protected health information. So Jennifer mentioned that there are state applicable privacy laws. So as I sort of do my thought pattern and thinking about, I have telehealth services I'm offering. I have patients from in-state and out-of-state. Of course, I'm located in-state, even though I might be doing virtual services in-state. And I'm licensed here. So what privacy sort of checklist should I be going through in my head in terms of whether or not my technology is tracking them and I might be in violation of federal or state law?
Excuse me. Yeah. So I think the first thing you have to do really is to walk through your workflow and your user experience and, ask yourself, where are the hotspots according to the guidance that we have available to us now? And so, Jennifer sort of alluded to some of this a little bit earlier, but, on the unauthenticated web pages, so let's just call it the web pages that are before the paywall or before someone creates an account, there's really three hotspots from a HIPAA perspective. And those hotspots are a scheduling app, right? So you have a great website and you want to get those prospective patients in the door. So you offer them an easy way to schedule and get on your calendar. HIPAA takes the position that that scheduling app is collecting PHI. And so at that point, even though you're on the unauthenticated website, you are actually collecting PHI and HIPAA's rules apply. So if, the prime example in this sign is, I go to Dr. Sylvia's website and I go to sign in for I go to sign up for a calendar invite to talk to Dr. Sylvia. And I decide, you know what, I changed my mind. I'm going to go somewhere else or see, Dr. Jennifer. And all of a sudden I start getting inundated with retargeting messages on the side of my Facebook page, right? So showing me how great Dr. Sylvia is and why I should come back and schedule my appointment. OCR is taking the position that's an impermissible use of PHI. So that's sort of the first bucket and the first example that I would say steer away from. The other two buckets are really, quite easy to kind of understand as well. The second one being, hey, if you are a condition specific website, right? So if you are so nuanced that, folks are coming to your to your website for this specific issue, and the OCR guidance actually gives women's pregnancy and miscarriages as the example. But if you're going to that website, any information collected on that website, because it is so condition specific and can identify IP address to individuals seeking information about miscarriage, OCR says that's PHI. And so sharing that back with Facebook or with Google or with, name your social media company, that could be considered a violation of HIPAA. The third bucket is everybody's favorite page, and it's where most cart abandonment issues in user experiences happen. It's the account registration page. You have those great web forms and they say, give me your name and your address and all of that other great information you need. And again, I decide, well, you know what, I'm going to go see Dr. Jennifer. And, I leave. And again, you inundate me with advertisements and marketing material. Again, OCR takes a position that if someone's actually entering that information and they look like they're intending to sign up for your website, create an account, that information is PHI. So again, your privacy checklist really doesn't start at account creation. It starts the moment the user comes to your website and really depends on what your workflow is. And so what we tell our clients is, look, map out your workflow, understand where information gets a little nuanced, understand where you're asking medical question, like a medical questionnaire. See a lot of great websites that give free advice based off of a PHQ-9. I think I'm saying that right. And they collect a ton of information, and the user drops off. All of a sudden, the user starts getting advertisements for the type of mental health service that was specific to the website. Those are the problem areas. And so staying away from those kind of buckets of issues and types of onboarding experiences until that user has created the account and you are treating that like PHI. What we've been telling our clients is that you should really steer away from that type of activity.
I have an observation and a question for you. So exceedingly helpful, and I think Jennifer, sort of the first pass, sort of laying the foundation, Erin coming with the second pass, because it is really complicated in understanding what this means for me as a provider. And I think as a hypothetical provider, of course. So Erin, I want to just sort of underscore a certain point here. This is a conference about telehealth, right? But I think it also is inclusive of virtual modalities and the virtual experience. And so the reason why this is so important, right, from my perspective, is that it's a whole package. That when your patient comes in, we, our panelists with Caitlin and Jade, they were talking about the telehealth interaction. This is sort of the outer layer, the wraparound of a virtual experience for patients, that it's the virtual front door, as it were, right? And so when we think about this in the context of this telehealth discussion, we need to be thinking about our virtual front door. And what Jennifer and Erin are laying out is, are you doing the sort of hygiene work to make sure your front door is safe and appropriate and has the kind of confidentiality that you would want around it, that if you're going in person. So that's an observation. And then Erin, as a follow-up, we're now seeing I want to hone in on the scheduling piece, because I think there's a real close nexus between that and the actual sort of front door of a telehealth visit. And the use of chatbots. So chatbots that, as you're scheduling, they can ask you questions like, how can I help you? And if you have questions, then put them in. So how is that piece treated if I'm typing in personal information there? Is that a front door? It may not be asking me for my PHI. It may be just generally asking me for help, but I'm typing in maybe really specific PHI.
Yeah, so that's a great question. I like the call out to the digital front door. I usually say we're just digitizing the front office experience, right? We're giving you the clipboard on a computer. And so getting to your chatbot question, I love working with clients that are looking to implement chatbots, because essentially I think that there is a really high correlation with how helpful chatbots can be to making that onboarding experience much easier. And so there's a lot of use cases for chatbots. To your question specifically, about a general chatbot that's looking to engage in a question and answer with the user. One thing that we're always wanting to be careful of, and something that I know Caitlin and Jade always impress upon our clients, is that the practice of medicine is something that it is something you feel, right? It is something that's a relationship that's created between you and your doctor. And so if I go to a website that is owned and operated by a hospital system, a medical provider, and all of a sudden I get access to this great, chat bot, and I start telling you, well, I'm having this symptom and I'm not feeling well, and my head hurts, and it starts spitting out, well, you could be suffering from this or from that. We tell our clients that you should really be careful with the information that it is giving, because you don't want to cross that line into the practice of medicine unless that chatbot is somehow approved as a software, as a medical device from the FDA, and also it's been reviewed and monitored by a licensed physician who is completely comfortable with the types of answers that it is allowed to give. We really haven't seen a lot of that technology coming forward yet. But for our clients who want to give like more of a general educational, sort of, I guess maybe summary of what could be happening or how they could receive help, what we typically tell our clients is make sure that whatever advice is being given or whatever, go forward recommendations are being given, they're rooted in truth, right? And so, we saw some of this like in the COVID-19 not that COVID-19 is over, but during the COVID-19 pandemic, a lot of these chatbots were, taking in people's symptoms and saying, well, it could be COVID-19, it could be the flu, it could be this. What we recommended was, look, instead of trying to pinpoint it, say, well, your symptoms sound like they are consistent with what the CDC defines as the COVID-19 variant. Something, a symptom checker, a advice. I don't want to call it advice, but a sort of a summary list of information that comes with the source of truth, so that if anybody were to call into question, hey, are you really practicing medicine? Is that chatbot really taking the place of a doctor? We could say, no, it's giving the same advice that you would get if you went to the CDC website or WebMD and you typed in what your symptoms were and you really kind of explained what you were feeling. It's no different than the Google search bar. And so we really counsel our clients, make sure that relationship, that we keep that relationship between doctor and patient so high up on the totem pole, that this chatbot at no time until the technology gets there is able to replace that.
The other thing is, a lot of times clients have asked me about them. They're being run by third parties, some of the big AI players in the space. To the extent the information being collected is PHI, which it often is, you need a business associate agreement, going back to the conversation we discussed before. So important to remember that as well.
Beautifully closed, Jennifer. You closed sort of that second piece. And I think, Erin, you took it to a place that's super fascinating and interesting, and I think really elucidates sort of like the next generation of issues. I'm going to have all of the speakers come on. We're almost at time. We have 3 minutes. And this is going to be one of the most rapid fire rounds you've ever seen, because you're just going to have the option of saying one word or another. So in looking towards the future for everyone that's assembled here and who will listen to this webinar, and looking at the challenges to digital transformation and removing structural barriers to access and really addressing long-term sustainability, what is the biggest rate limiting factor here? Is it going to be one, payment and coverage for these new technologies and existing ones that are well established, like telehealth? So coverage and payment. Is it going to be regulatory complexity? Is the second option, or is it the third? Is it the human factor, the sort of the lag time that it takes for humans to really feel comfortable and adopt new approaches? So I'm going to go ahead and start with Carol. Is it the human factor that's going to be the rate limiting factor to virtual transformations? Is it going to be lack of payment, or is it going to be regulatory complexity?
Yes.
Caitlin?
Regulatory complexity.
Jade?
Regulatory complexity.
Erin?
I'm going to say the human factor.
I was also going to say the human factor.
So you heard it here, folks. And my answer is payment. If it's not paid, it's not going to happen. So, okay, with that, I'd like to thank all of you. This has been a hugely educational and informative session and a great way to end out our annual conference. And we appreciate the time that you, our audience, have taken to join us on this journey. We look forward to seeing you next year. And with that, I'm going to wrap up this session, and we'll see you again soon at our next ETRC webinar.